You're on call, it's 3 a.m., and that page comes in. Massive hematemesis, known history of cirrhosis. Your heart starts pounding. Yep, this is the big one. Welcome to our explainer, where today we are going to break down esophageal variceal bleeding into a super manageable, high-yield guide so you can walk into that room and absolutely master this critical emergency. So, to really get a handle on this, we need a solid plan. First, we'll cover the setup, why this even happens. Then we'll dive into the emergency itself, your first 15 minutes. After that, the intervention, how to actually stop the bleed. We'll also cover what to do when things escalate. And finally, the aftermath, making sure this doesn't happen again. All right, first things first, before we can even think about treating the emergency, we have to understand the fundamental plumbing problem that sets the whole stage for this disaster. And it all starts right here. See, in a patient with cirrhosis, their liver is scarred up and rigid. So all the blood that's trying to flow through the main portal vein, well, it hits a massive traffic jam. This creates a huge backup of pressure. And that right there is the core problem, portal hypertension. So to try and relieve some of this pressure, the body gets creative. It starts rerouting blood through these smaller collateral veins, especially the ones down in the esophagus. But here's the thing. These veins were never built for this kind of high-pressure flow. They just swell up like overinflated balloons, becoming these fragile, thin-walled varices, just waiting for one thing, to pop. Okay, so let's jump to the moment of crisis. The patient is right there in front of you. What are the absolute non-negotiable things you have to do in those first 15 minutes? Time is everything, and you've got to be systematic. Step 1, ABCs. Protect their airway, get 2 large-bore IVs in, and start pumping in fluids. At the same time, you're giving vasoactive drugs like octreotide to help lower that portal pressure. Then get those prophylactic antibiotics on board because infection is a huge risk here. And finally, and this is so important, you've got to be smart about your transfusion strategy. This number is your new best friend, 7. Your goal is a hemoglobin of around 7. Now, I know it feels completely wrong to hold back blood from someone who's actively bleeding, but over-transfusing is seriously dangerous. If you push that hemoglobin too high, you actually raise the portal pressure and can literally just fuel the fire, making the bleeding even worse. And here is a massive takeaway, not just for your board exams, but for your actual practice. A restrictive transfusion strategy isn't just some idea. It is proven to decrease mortality and lower rebleeding rates. It's one of those cases where, believe it or not, less is truly more. Okay, so we've stabilized the patient, we've bought ourselves some precious time. Now, the focus shifts. We've got to get control of the source and shut this hemorrhage down for good. The patient's stable. So, the big question is, what's our number one tool for actually turning off the faucet? How do we achieve hemostasis? The answer is endoscopic variceal ligation, or what we call EVL. This is the gold standard, no question. As soon as the patient's stable enough, we take them for an upper endoscopy, we find that bleeding varix, and we deploy these tiny little rubber bands to basically strangle it and choke off its blood supply. And the goal is to get this done fast, within 24 hours. But what if the bleeding is just out of control, or maybe endoscopy isn't available right this second? You need a bridge. That's where something like a Blakemore tube comes in. It uses these inflated balloons to put direct pressure on the bleed and stop the hemorrhage. It is absolutely a temporary fix, but it can buy you that critical time you need to get to a real solution like EVL. But what happens when standard therapy just isn't cutting it? What do you do for the sickest of the sick, the ones who are at the absolute highest risk of rebleeding and dying? So we have to get good at spotting these high-risk patients early on. We're talking about folks with more advanced liver disease, what we call Child-Pugh Class C, or maybe a Class B patient who has active spurting bleeding when we first scope them. For them, just banding those varices, it's often not going to be enough. And look at this. A landmark trial showed a really stark difference for these high-risk patients. With just standard therapy, half of them bled again within a year. But with a procedure called an early TIPS, an incredible 97% of them were free from rebleeding, and the survival numbers are just as mind-blowing. So this procedure is called a transjugular intrahepatic portosystemic shunt, or TIPS for short. It basically creates a new pathway for blood to just bypass that scarred-up liver, which dramatically lowers the portal pressure. For these really high-risk patients, getting a TIPS done within 72 hours boosts their 1-year survival from 61% all the way up to 86%. It's a total game changer. So, We've controlled the acute bleed, we've put out the fire, but our job is not done. Not even close. The focus has to shift now from emergency treatment to long-term prevention. And this next phase is absolutely critical. It's called secondary prophylaxis. See, once a patient has had one variceal bleed, their risk of having another one is just sky high. So our goal now is to do everything in our power to make sure that never happens. And we basically use a two-pronged attack. On the medical side, we start them on lifelong, non-selective beta blockers, drugs like propranolol or nadolol, to just systematically keep that portal pressure down. And then, on the endoscopic side, we bring them back for more EVL sessions, banding any varices that are left until they are completely gone. The combination of the two is really key. And one last super high yield point for you. Don't forget about primary prophylaxis. This is all about preventing the first bleed from ever even happening. So if we find medium to large varices on a screening endoscopy, we should be starting that patient on either beta blockers or doing prophylactic banding right then and there to stop a disaster before it starts. Which kind of leaves us with this final thought, right? We've gone from being reactive to being proactive, from just salvage therapies to targeted evidence-based prevention. So as our ability to screen and risk stratify and treat these patients gets better and better, are we getting closer to a future where this terrifying, life-threatening hemorrhage becomes something we can actually prevent, a never event?